can go towards the various carcinogens present in smoke. At least name
Okay.
4 to 5 of them, which are the
Thank you,
most
sir.
common ones and most important non carcinogens. That will be
Okay, sir.
useful.
Okay, sir.
Yes, Dr. Mani, you can
Okay.
direct the discussion further,
Yes, sir.
please.
Okay, sir. Coming to the general examination, Prashnath is Eastern Cooperative Oncology Group performance status of 1, conscious oriented, no pallor or icterus or clubbing or pedal edema, no peripheral lymphadenopathy. His vitals are normal, no JVP elevation. Height is 170 centimeter, weight 65 kg. BSA is about 1.74 meter square. BMI of 22.5 kg per meter square. There were no other general examination, but no facial edema, no conjunctival congestion, engorged neck or chest veins, or upper limb edema or hoarseness of voice, fundus no papilledema, no ptosis, meiosis, or enophthalmos. Coming to systemic examination, respiratory system inspection, chest wall is bilaterally symmetrical, moves equally with respiration, no scars or sinuses. Coming to palpation, trachea is in midline, chest wall measurements and palpatory findings showed bilateral symmetrical moves equally with the respiration. Percussion, all areas are normal resonant note. Auscultation, normal vesicular blood sounds were heard in all areas. Rhonchi was heard in right infraclavicular and suprascapular areas. Vocal resonance was normal in all other areas. CVS S1 S2 heard, no murmur, per-abdomen, no organomegaly or no Moss felt. Rectal and genital examination was normal. CNS, no focal neurological deficit, no papilledema. Summary, 64 years old male with comorbidities of diabetes mellitus, hypertension, and atrial fibrillation on supportive medications, and who was a former smoker with 6 pack years. Presented with complaints of progressive cough with dyspnea for 1.5 months and 2 episodes of hemoptysis over past 2 weeks associated with fatigue, and on examination found to have wheeze over the right infraclavicular and suprascapular areas, otherwise no other findings. The differential diagnosis would be still considering the age with smoking risk factor, and then symptoms of cough, dyspnea, and hemoptysis. My differential diagnosis would be right primary lung malignancy or metastatic lung disease, or any infective etiology still have to be ruled out, other benign causes.
Okay. So in the examination, is there any features of atrial fibrillation? You didn't mention about that.
No, sir. At the time of actually, patient is known as a paroxysmal AF, sir. Patient's already on regular medications. At the time of presenting, a patient did not pulse rate were regular, sir.
Okay. Please don't miss out on such
Okay,
things
sir.
that may not be
Sir.
important, but I mean,
Okay,
it is important,
Okay,
not the significant findings. Okay.
Yes, sir. Yes, sir.
And
Yes.
in the examination, what is the importance of neurological examination here?
So neurological examination, first, whether there is any neurological deficit to rule out any metastatic. If patient has metastatic lung disease to brain, patient can have neurological deficits due to cerebral edema. Patient can have papilledema, or a patient can have paraneoplastic syndromes like myasthenia syndrome, or any sensory disturbances like some axonal neuropathy can cause, and then cerebral ataxia can.
Yes, right. So because you mentioned about fatigue, so that can be due to disease, but
Okay,
sometimes that may be a manifestation of a paraneoplastic neurological syndrome. And Horner's, as someone has already mentioned, the chat.
Yes.
So that's it. Dr. Akil, you have anything to add?
Yeah. So I think that was important. Most common symptoms for CNS will be due to the disease per se, due to metastatic disease,
Okay,
and sometimes rarely due to paraneoplastic. But definitely you should be aware of the all the common paraneoplastic syndromes associated with the cancers, especially small cell cancers. And if the examiner will definitely in the small cell, the viva will go towards paraneoplastic, that is for sure. So you should be aware of in detail. We'll come to that as well. So which antibodies are responsible, what paraneoplastic syndrome is associated with which antibody. I think all these factors will be important. Should we ask it now or later, Dr. Manu?
Yeah, we can discuss it now itself. No.
Yes.
Cover it.
Which is the most common paraneoplastic syndrome in small cell
Uh,
cancer?
SIADH, sir.
SID, very good. SID. So,
Yes,
how
sir.
is it caused? Why it is caused, and how will you diagnose it?
Because of the ectopic ACTH secretion, it can be diagnosed with patient can have euvolemic hyponatremia with urine sodium will be increased more than 40 millimoles, and then urine osmolarity will be increased. Serum osmolarity will be decreased, and decreased serum uric acid can also be there.
Okay. So,
And
what is
patient
the
can clinical
hyponet?
manifestations of yes, clinical
Yes.
manifestations of hyponatremia can be there if like disorientation or augmentation or confusion or fatigue can be there.
Okay. Was there any some symptoms in this patient
No, sir, except fatigue, no other symptoms were there, sir.
except fatigue? Others is not good. Okay.
Yes, sir.
Okay. So, so if there are any suggestions of hyponatremia in the labs, for example, sodium is around 120,
No, sir.
but the patient
No,
doesn't
sir.
have any symptom, what will you do? How will you manage it?
Treat the disease, sir. Okay,
Treat the disease.
like, treat the disease, and then I can give supportive IV fluids if there is no contraindications, or under salt-rich diet, I will advise.
Okay. So, but if
Yes.
there is SIADH and you are giving IV fluids, will
Uh,
it improve or
I will
complicate this?
Actually,
Complicate.
sorry, sir. I have to restrict the free fluid intake. Salt-rich diet we have to give, and then
So,
I'll treat
so
the
it
disease, sir.
So actually, here you would the point is correct, but there needs to be a balance because you are going to
Yes,
start
sir.
chemotherapy as well, and there is
Yes, sir.
expectation of some amount of tumor lysis as well. So you cannot
Okay, sir.
completely restrict the fluid as well, and you cannot
Yes, yes,
completely
sir.
give
Okay,
so much of fluid as well.
okay,
So you will say
okay, sir.
that I will monitor intake output very closely, and
Okay,
will
okay, sir.
try to have 500 ml of negative balance. Dr. Manu,
Okay,
is
okay,
it
sir.
correct?
Yes, Dr. Yes, I agree. And
Yes.
just one question on that. What is the essential difference in the management of endocrine versus neurological syndromes in lung cancer? I mean, paraneoplastic.
Sir, I don't get you, sir.
No, treatment part, endocrine paraneoplastic manifestations and neurological paraneoplastic manifestations. What is the essential difference?
Actually,
Treatment of this.
it can be actually it can be reversible in we have to both the cases we should treat the disease, sir. Here in neurological and mostly reversible, sir. We should we may need to consider for other drugs like
Yes.
steroids or Plex or tacrolimus or
Correct.
something
So
like that will be
endocrine, the
needed, sir.
treatment is treatment of the disease, whereas in
This is yes,
neurological, it is not just the disease alone. You have
yes,
to
yes,
use other modalities. Okay,
yes, yes,
we can proceed.
yes.
So, so how will you work up this patient?
So, workup initially, since my differential diagnosis, close differential diagnosis is primary lung malignancy or metastatic lung disease, I'll first initially go for basic investigation of chest X-ray to look at any anatomical anatomical lesion is there or not, or since patient is having dyspnea also with throat NA, but clinically no evidence of effusion, but still I do chest X-ray initially, sir.
Okay.
And then followed by that, if I don't get anything or if at all,
Hello.
I think we lost his connection.
We lost the connection. Okay.
Yeah.
Only
Mhm.
Yes. Back. Okay.
Most of the time, when the patient is arriving to you, the patient will have some of the investigations with him or her. So most of the time, X-ray or sometimes a CT is already there. So in that case, do you want a repeat CT chest or you want a complete CT thorax of the pelvis versus FDG PET? Are you able to hear?
Now, can you hear me, sir?
Yes, yes, we can hear you.
Yeah.
I will go for a CT thorax abdomen pelvis or PET-CT, sir.
Okay.
And then after
Apart from that, mm,
from that, for confirmation of the lesion, if at all I found any lesion in the lung, I'll go for as I had my differential diagnosis. I'll go for confirmation with biopsy, sir, which may be image guided or bronchoscopy guided. Before
okay.
that, I will do basic investigations like CBC, coagulation profile, and other biochemical parameters. And see how it's
Okay. So what do you expect? What derangements are expected in the routine profile which you are doing?
in CBC patient maybe since patient is having hemoptysis, as per the history it's mild, but it has been national, I can expect anemia or also as a course of paraneoplastic also patient can have anemia or thrombocytosis or leukocytosis in CBC picture. And if there is any coagulated infections, consolidations, that patient can have increased wounds. In coagulation profile, already patient is so no case of atrial fibrillation test was on warfarin, but he has stopped 1.5 weeks back. So I will look for the coagulation will be normal so that I can proceed for biopsy. Another RFT and LFT parameters to do a CT thorax and pelvis with contrast, I should ensure whether creatinine is normal. And then the LFT parameters, I can put on any metastasis has been there. I can look for any derangement in the LFT parameters. Now from that, for planning of chemotherapy in later time, I need to ensure the adequacy of liver and kidney functions. And serology for precautions.
You should mention specifically about the tumor lysis, especially as we are
Tumor lysis.
suspecting, discussing small cell and also calcium electrolytes, including calcium levels.
Those for this. Electrolytes for the hyponatremia or patient has hypercalcemia of the but it's not common in the also can be in small cell. These are all the things which I will.
Okay, so do we have the investigations here?
Actually, it was all normal. Or left alone was deviant. 0.8, 105, 51, and 85. SGOT alone was 105.
Okay. What did the X-ray show?
This X-ray, this is the plain chest X-ray PA view of the patient. Properly positioned and adequate exposure. In this X-ray, trachea it used to be slightly deviated to the right, and then there is those cardiomegaly is present. And then into the lung fields, there is increased bilateral bronchovascular markings. But other than that, doubtful patchy opacity present below the right mid-rib of the clavicle. Otherwise, bone, rib cage, and then other soft tissue or normal.
So there is striking cardiomegaly, right?
Yes, sir, striking cardiomegaly.
Okay. What about the other reports?
Yes. Is the CT report. My impression, there was a soft tissue attenuation nodule with speculated margin seen in the right lung upper lobe with a significant mediastinal and intra-abdominal nodes. The size of the lesion was 1.9 into 1.6 centimeter. There was moderate to massive pericardial effusion, few hypoattenuation lesion in liver, the audience measuring 1.2 centimeters in the segment for possible metastasis, and prominent bilateral level 2 cervical nodes of approximate size of 1.1 centimeter on the right side.
So if the patient has come with the CT scan already done, will you ask for a PET?
Since this patient since already like a stage 4 disease, I won't for PETs. But otherwise, if I'm going for a radical internet patient is not having any significant metastatic nodes or any nodes, I ask for PET-CT for staging.
If PET-CT is not available, what else? What all investigation will do if you're suspecting small cell lung cancer?
Can go for CT thorax abdominal. Apart from that, I can go for a bone scan, and then for bony metastasis, and for the MRI brain for brain metastasis.
So you need to do a bone scan and bone marrow examination. So does the PET scan really upstage the disease compared to the other investigations? In what percentage of patients?
Around 10 to 15%. I not this number.
Sorry, how much?
10 to 15%.
Yeah, that is generally PET scan upstates in all the cancers. We say this figure 10 to 15. I think in small cell it's even lesser, like it's between 5 to 10%. But definitely with availability and convenience, it is always better to go for PET-CT. But the number of patients who may be upstaged are much lesser compared to other malignancies.
Okay.
Yes, yes, Dr. Agil has put out some points.
Yeah, that is related to high risk features of cancer. For example, if a patient has a family history of cancer within first to third degree, there's a passive smoking exposure, history of TB, COPD, cooking index. That is what I was trying to highlight in the Taiwan study, talent study, which was there, and not using ventilator during cooking. These are related to the smoking and other related points. These are useful. Sometimes examiners, when asking specific points, they can ask these points. These are useful.
Because you mentioned this, what is the relevance of tuberculosis in lung cancer?
So it can be a patient had the previous history of tuberculosis, and the patient or hello, patient had developed fibrosis. Patient can develop scabrous carcinoma on the later time.
Yes, yes. I mean, this association was seen around 1% of the patients in one of the Indian studies. And also, most importantly, around in India, lung cancer patients around more than 20 to 25% might have already received ATT before we start treatment for
Correct.
lung cancer. And also, there are a lot of implications during treatment, including interactions with ATT. So TB is very important here also. Okay, so the question in the chat box is whether bone marrow is mandatory. I mean, if we are doing PET, there is no need to do bone marrow. But otherwise, if you're not doing PET, it is preferable to do bone marrow, especially if there are some abnormalities in the blood counts. Even otherwise, generally bone marrow is recommended in the pre-PET era.
Yeah. Presently, I think nobody uses bone marrow biopsy, but yes, this one should be known that if it is not feasible to do PET and a patient is having some changes in the counts, that means two cells are at least affected out of hemoglobin platelet WC, bone marrow will be recommended.
Yes. So Dr. Kale, you can, so CT scan is shown metastatic disease with the pericardial effusion. There is no features of tamponade, no?
No, sir. No tamponade. The patient vitals were all stable. Even JVP was not elevated.
Okay. You mentioned that.
No
Okay. Then what will you do?
Then for the confirmatory, the information, then biopsies.
You must do an urgent echo also. So there may be pending tamponade before you're planning for a bronchoscopic or guided biopsy. First, do an echo and assess the effusion status.
Yeah. So assessing the effusion, pericardial effusion in this patient becomes really important because the patient has history of AF, the patient has significant pericardial effusion visible in the X-ray. So you should assess it either preferable is by 2D echo, or else you can do a just simple ultrasound and see the thickness of the left ventricular apex to the tip of the pericardium. If that is more than 10 mm, that is required to be tapped at least.
Initially, for this patient, we tried for a bronchoscopy guided final aspiration, but it was inconclusive. So we went with
But the CT scan was like, is it likely to be accessible in bronchoscopy?
no, sir. Not nearby any large arteries or bronchs. So not the case, but
Yeah.
initially, but
I
it
think
was
yes, in such cases, we can directly go for a CT guided biopsy. And after, if you have some anticoagulation, after stopping that, that should not be forgotten. Okay.
we went for biopsy from the metastatic lesion in the liver, sir.
Okay.
Metastatic neuroendocrine carcinoma correlating with history and imaging findings. It was small cell carcinoma lung, and then you see that CK diffuse positive, synaptophysin diffuse positive, chromogran negative, and CD56 was also diffuse positive.
CK, synaptophysin, and CD56 positive.
Positive. Chromogran was negative.
Okay. Generally, what happens to TTF1 in small cell lung cancer?
It can be positive up to 80 to 85%. It can be positive.
Yes. Okay. All right. So this is biopsy from a lesion other than lung. So is there any difference between the small cell lung cancer and extrapulmonary small cell cancers? Are they the same or different?
95% of them, 3% that managed quiz, it is not same.
Yeah, management is somewhat same, but biologically these are different entities because the association with smoking is much lesser in extrapulmonary small cell cancers, and the propensity for brain metastasis is much lesser compared to the pulmonary small cell cancers. Okay. Anyway, so biopsy suggests your small cell lung cancer. So what is the final diagnosis?
Final diagnosis is stage 4 small cell lung cancer, extensive stage.
Okay. So what do you mean by limited?
Limited is stage 1, 2, 3 small cell lung cancer groups with lesion confined to one hemithorax, and all of the lesion can be encompassed within a tolerable radiation.
Okay. All right.
Okay. So I think you should avoid the term stage 1, 2, 3, and stage 4 because that is not a standard nomenclature when you are discussing small cell. But yes, ED, extensive and small, limited, you gave the correct definition. So it is basically based on the radiation portals, as you highlighted. And also, when you're seeing the pathology report, here we can't see the details of the pathologic assessment on the. It is mainly telling directly metastatic NEC and then IHC is there. So I think most of the time our pathologists report it in detail that sheets of cells are arranged and all have small cells, large nucleus. So all these details are also become important sometimes. And when it is so obvious that most of the time, even it doesn't require too much, 3 or 4 IHCs also, single IHC might be enough when you want to save the IHCs. So pathological description is also important, though it is not mentioned here, but in other cases, most of the time it is mentioned. And that is very pathognomic of a small cell.
So how will you manage this patient?
This patient is present with extensive stage small cell lung cancer. I will counsel patient for my and first do basic blood investigation workups to see whether patient is fit enough, like CBC and biochemical parameters.
That we've already done, no? That's all normal.
That's all normal. So I'll plan for my first line of management would be chemoimmunotherapy. The Solizumab, 1200 milligram day 1 plus the triposide of 100 mg per meter square, day 1 to 3, plus carboplatin is called in our, I think, carboplatin of UC5, day 1, every 3 weeks for 4 cycles, followed by reassessment. In the reassessment, we will look for since patient initially underwent CT thorax abdomen pelvis, and since it's extensive, we will do CT thorax abdomen pelvis and MRI brain also, because earlier patient was not symptomatic for any brain met. So by reassessment time, we will do along with the CT thorax
Oh,
MRI
yeah.
brain
So
also.
this one question. So you will do an MRI brain for this patient even if he's asymptomatic?
No, sir. In our if we don't do routinely, sir, unless the patient is symptomatic.
Okay. Okay. So your plan is etoposide, carboplatin, and atezolizumab.
Atezolizumab for 4 cycles every 3 weeks, followed by reassessment. If patient has adequate response, we'll go for atezolizumab maintenance, and then follow up MRI, or I will consider for PCAs.
Okay. So you think immunotherapy will be beneficial? So why are you choosing atezolizumab? What is the other option?
Other option is durvalumab cascade.
Okay.
Also
Why do you
can-
prefer atezolizumab?
Yeah, I think in exams it will be better to mention both the options directly without giving preference to one specific drug.
Okay.
We can use either of the two. Both have not been directly compared, and both have shown survival benefits. So in the exams, you can give both the options, and on if the examiner asks in the next step, you will have to mention the differences in the trials, and you can mention about the cost aspect as well, why you are preferring one of the over the other. You can mention that. And also, since you mentioned that MRI brain is not done as per the institutional protocol, this is fine. But in the ideal scenario, going by the books and going by the standard teaching, MRI brain should be recommended. But yes, I agree. Some institutes, including ours, in extensive stage, do not perform it routinely. So that is fine. But you can should be aware that MRI brain is ideally indicated. But if resources are constrained, it can be avoided if the patient doesn't have symptoms. And Dr. Manu, I think I made the correct point.
Yes, yes. I mean, if you're using immunotherapy, I think it is less important, especially when you use atezolizumab. There's no difference. But if you're not using immunotherapy, I think you should mention that ideally it should be done. But I mean, practice, I mean, most of us are not doing. So as Dr. Akhil mentioned, you just say chemoimmunotherapy as the next step. If the examiner asks, you need to discuss the differences between the trials. I mean, not in detail, but the basic principle. So what are the difference between these two trials? And if you prefer one molecule, what is the reason?
For atezolizumab, because it's like 4 cycles followed by atezolizumab maintenance. Durvalumab is not recommended in durvalumab trial.
Sorry, Kale, I think your voice is not very clear.
Hello, sir. Can you hear me now, sir?
Yes, yes, yes. Now it's better.
The differences is like in atezolizumab arm, we use only atezolizumab and carboplatin.
Yes.
Here, either carboplatin or cisplatin is used in cascade in durvalumab. And then it's only 4 cycles are allowed in atezolizumab. Here, either 4 or 6 cycles, 2 6 cycles are allowed. And then prophylactic radiation is allowed in atezolizumab group, but in durvalumab it's not given as per trial. And then overall survival wise, it's almost 12 months versus 10 months. Here it's almost 13 months versus 10 months.
Okay.
More equal.
Okay. So generally, you are more comfortable in using carboplatin along with the immunotherapy, so you prefer atezolizumab. Okay. In practice, what is the main obstacle in using immunotherapy in small cell lung cancer patients? I mean, leave apart the cost. Otherwise, what is your concern in real world setting?
Consolidation RT or if patient has very good response post 4 cycles initial chemoimmunotherapy and then patients waiting for consolidation thoracic there may be
Okay, that is one point I agree. So you mean there is a role for consolidation RT in extensive small cell lung cancer. If there is good response, we can irradiate the residue, and that is shown to have a survival benefit, right? So
Yes,
that is not, that is not included for the atezolizumab trial. I think for the other trial that is permitted. In the IM passion trial, the thoracic RT is not permitted. Okay, that is one point. Then otherwise,
patient had extensive lung disease giving atezolizumab. If patient develops radiation immunity still it hamper the lung functions.
yeah, and the problems in practice, most of our patients' performance status is not very good. So all these trials clearly say it should be in good performance status patients. But small cell lung cancer most of the time presents with poor performance status, and we need to give some tailored therapy. And many a time it may not be practical to use immunotherapy also. Okay. So if you're using immunotherapy, what all investigations extra will you do? What all things will you look for?
For in our we usually do a thyroid function test and cortisol.
Okay.
Okay. Then we will monitor for the 3 months.
What is the response rate you are expecting with these drugs, with chemotherapy or even immunotherapy?
Response of survival benefit of first almost
No. First give response rate. First give a response rate. The question is, so the question is with platinum agents, what is the percentage of patients who are expected to show a response in small cell lung cancer? Do you expect it to be low, medium, high? If either of these three, what are the rough percentage?
chemosensitive disease, so medium,
Yeah.
medium to high, medium.
So response rate is expected to be high, correct? 70 to 80% patient should show some improvement, correct? In the chat box, somebody mentioned 30%. That's quite low. That is 30 to 35% is expected even in adenocarcinoma lung with pemetrexed carbo alone. And when you are adding treatments like bevacizumab in adenocarcinoma, you will add 5% to 10%. If you are adding immunotherapy further to it, again 15 to 20% addition, making it between 50 to 60% average. In small cell lung cancer, you are getting 80 to 90% responses. So, what is the benefit of adding immunotherapy? It is unlikely to add response rates. If it is adding, it will add only 5% maximum. So, what's the benefit of adding immunotherapy in such situation? Your voice is breaking.
Hello.
Yeah.
There has been minimal overall survival benefit wise. It has been found to have minimal overall survival.
So, how that overall survival benefit comes? If it is not increasing responses, how the survival benefit is coming? Yes. I think Pushpinder was messaged that durability of response it increases. So all the small cell cancers and even some other cancers are known to have very good responses to platinums, but the problem is that that response is not sustained for longer duration. And here the function of the immunotherapy is to somehow sustain the responses. And it was seen in both these trials that both the TIZO and DURVA trial, if you are adding it concurrent with chemotherapy and then maintaining it, it is going to show some benefit. Though there are negative trial of adjuvant pembro, there is negative trial of adjuvant nivo. So I think it is the trial designs were also responsible for the same. The trial had adjuvant pembro, the trial had adjuvant nivo, but that was after completion of the chemotherapy. And here finally, the design which succeeded in both the trials was concurrent with chemotherapy and then later continuing as maintenance treatment. So this is something different from urinary bladder cancer, which is another disease where you see that patients have good response to chemotherapy, but responses are not sustained. So maintenance avelumab has shown survival benefit. Similarly, now there is data of Gemcis Neo as well. Yeah.
So essentially, how is the management different from non-small cell lung cancer? With molecular testing here, any role for molecular testing?
Molecular testing, it's more within non-small cell cancer, especially adenocarcinoma. Here it has no role.
You know of any molecular subtypes for small cell lung cancer?
So classic and variant forms. In that ASCL1, the
Yes.
potential utility factor, neural ENT, they're not.
Yes, so there are 4 subtypes, and I mean, in future maybe we may get more idea on which patients are more likely to respond to immunotherapy and also. So that is not in the, I mean, clinical stage. It's still under the research stage, but it may provide some insights on which your patients are likely to respond to immunotherapy. So you should know about the molecular subtypes of small cell lung cancer also. Otherwise, there is no role for molecular testing.
In the we see in small cell, regular training radiation, but it means we don't give in non-small cell.
Okay. So this patient, are you planning? Will you plan for prophylactic anal radiation?
Those we give only 2 cycles of participants if we most of the cognitive reassessment, patient was found to have stable disease. So with that we continued the assessment maintenance. After 4 months of maintenance, the patient developed relapse with brain mets. The patient had symptomatic patient was found to have brain mets. Brain only mets, but otherwise other lesions are all stable. Then we gave palliative whole brain RP for the lesion, and then we continued that assessment. Now patient had systemic progression also after 4 months. Now patient has 10 lines.
So just a few words on management of relapsed small cell lung cancer. How will you manage when there is relapse?
When there is relapse, option would be second or lumpectomy.
So what about the platinum resistance in small cell lung cancer? What is the definition?
Platinum sensitivity, the incidence is less than or equal to 6 months or more than 6 months.
No. I mean, small cell, it's not 6 months, no?
3 months. 3 months, more than
Yes.
3 months.
3 months. So it's more than 3 months, you can re-challenge with the platinum. Otherwise, the option is stop it again. Okay.
Apart from topotecan, what are the other options? One of which is going to be available shortly in India.
Yes.
Lumpectomy and tarlatamab.
You look into tarlatamab. Okay. Both are going to be available shortly, I think. That would be good.
What class of drug is lurbinectedin?
So lurbinectedin is an alkaloid.
What is the mechanism?
So it induces apoptosis, has inhibits transcription and causes DNA double stranded breaks also. Pleiotropic effects.
Okay. So RNA polymerase inhibitor, right? Okay. Yeah. So that's it, Dr. Agli. You want to add something? And when you mention about chemotherapy regimens, clearly be ready to write the prescription. You should know everything. Like in the clinic, you will be just filling out the templates, But in exam, I think you should be knowing to completely write a chemo prescription. So all those things should you should be mentioning.
Yeah. Also, when you are not giving PCI, is there any data to avoid PCI by using any surveillance?
Yes, we can do an MRI surveillance like every 3 months. Like every 3 months, it showed almost equal surveillance, like giving PCI for surveillance or the MRI surveillance alone. And
Okay. So, what is this study? From which country?
Maverick,
Huh?
Maverick.
Japanese study, basically, correct? Yeah.
Yeah, so read about those trials. Like, I mean, now the significance is less in the immunotherapy era, but all these traditional trials on PCA, you read these two conflicting trials, both in extensive and limited, how they are different. So you should have some basic idea about these trials.
I think we have completed most of the relevant discussions, but yes, there needs to be a fine tuning, especially relevant to the paraneoplastic syndrome. This is a thing which you cannot answer if you have not read it well. Otherwise, it becomes difficult to answer. Apart from these points, the relevant trials of immunotherapy are important to understand and get idea. The differences in the trial should be relevant and should be very specific, and you should be able to enumerate them rapidly. At the same time, the second line treatment options, especially the data of the tarlatamab, lurbinectedin, are becoming important since we are will getting these drugs shortly as well. Apart from these, the drug sometimes we utilize taxanes as well, paclitaxel or docetaxel in the second line setting, the second or third lines. These are important points which we see because most of the time patients' performance status deteriorate rapidly, but some patients have good performance status and you are going to utilize third line or fourth line treatment as well, but these are smaller fractions of the patients. You should be aware of the available options. Also, re-challenge of the platinum is very important point, which was already highlighted by Dr. Manu. So I think these are the relevant and important points. And also some times we prefer utilizing prephase chemotherapy instead of giving full dose chemotherapy in the first go. Most of the time, since it was being discussed that patients have poor performance status, we give something like prephase chemotherapy like there is an option to give either single agent carboplatin or reduce dose carbonate to on 2 days. All these are customized options, though these are the options which can be utilized in the practice depending on the patient's performance status. We have
I think
discussed
Dr.
that as
Akhil
well.
summarized everything, and Dr. Kale has presented well. So always streamline the discussions relevant to your particular patient, starting from the history, and don't miss out on the positive findings. And lung cancer, smoking related things, you have to read well, epidemiological things. Then other things related to small cell, Dr. Akhil has already explained. Okay. Okay. And I think we can wind up. Thank you, Dr. Khalid. Dr. Akhil, we can wind up, no? I mean, Dr. Munir.
Yeah, sure. We
Thank
can.
you, Manu Prasad sir and Akhil Kapoor sir for your time.
All the best. Yeah.
Thank you.
Best of luck.
Thank you so much.
Okay, thank you, Akhil. Thank you,
Sir.
Manu, for handling this the session, and this very good presentation. Many practical relevant issues were discussed. So thank you. We'll catch up. We'll be sharing up with the new presentation next month. Thank you. Thank you, Dr. Munir, for
Thank you.
coordinating.
Good night. Good night, everyone. Okay.
Good night.